Good morning, everyone. I'm really delighted to be here. I'm always excited to have these opportunities to connect with trainees and other researchers, just to talk about, the work that I do. And sometimes it can be complicated, but, applied work is also really rewarding. So I'll share a little bit about my experience. So I did want to acknowledge that I'm joining you here from Treaty 6 territory in Edmonton at the University of Alberta. This is also where I live with my family, my husband and 3-year-old daughter, Lucy, and would like to give gratitude to the original keepers and caretakers of Turtle Island for my privileges of sharing space with all of you today. So a little bit about my research program at the U of A. So I do lead an applied health policy and systems research lab called CARE. CARE is the acronym, which stands for Collaborative Applied Research for Equity in Health Policy and Systems. And the goal of CARE is to tackle complex public health and system issues or challenges, drawing on the broad field of health policy and systems research, and which also involves a lot of connection, relationship building, engagement with those working within and across the health system. And my definition of health system is broad, so it's beyond just the acute care system. As Tamal had introduced me in the beginning, I am a Canada Research Chair in Health System Integration. So I think health system integration really speaks to the focus of my work, which is really that integration between health and community to foster and promote health equity. So the lab works across 3 main research areas or thematic areas. One, a focus on promoting healthy Indigenous communities and families. A second research area focused on domestic and family violence responses within healthcare settings. So a lot of my work within gender-based violence is in the healthcare setting. However, as I just mentioned, it does involve engaging and working closely with the anti-violence sector in Alberta, as well as they play an important role in primary prevention and supporting survivors and their families. Another thematic area is focused on upstream change to address mental health inequities, and I feel that that really intersects a lot with the work that we do around domestic and family violence. And much of the work we do is really working in community and primary care settings. So some of the interventions or strategies, programs we deliver are in community settings, drawing on community-based participatory research approaches, but also primary care. So I'll talk a little bit more about my journey in a moment, but much of my work has been in community-based primary healthcare settings, and primary care being important to me because it is the first place or point of care where someone, an individual or family member seeks health services. And the role that primary care can play in integrating across other systems is really important in addressing social determinants of health. So what is health policy and systems research? I usually always speak to this as some might not realize sort of the intricacies involved in this broad field. So it does seek to understand and improve how societies organize themselves. It is truly interdisciplinary. So I myself am trained as a social scientist, but I engage and work very closely with health economists, with political policy analysts, or political scientists, clinical epidemiologists. So it's really working across disciplines and across boundaries to improve and strengthen the health system and inform policies and programs. So, and it also helps us to get a better understanding of the broad, comprehensive picture of health systems and how they shape or influence the broader determinants of health. So a little bit about myself. So situating myself as an applied health policy and systems researcher. So I actually started off working very much at the grassroots in nonprofit organizations in global health. So I had always thought that I was going to work in global health settings. I was going to live abroad. But personal reasons had brought me back to Canada. And so my career trajectory ended up being building a program of research in the Canadian context in health policy and systems. But started off in global health, working in having the opportunity to work in many different countries, but a few where I've had spent quite a bit of time in include Ethiopia. So worked for a profit there called Mary Joy Aid. I worked there for a year. I led most of the grant writing, so supported with grant development, but also helped to facilitate an outreach program for HIV/AIDS in the community. That spurred my interest in graduate studies, enrolled in a master's of program at the University of Toronto in public health and medical anthropology. And that led me to Krong, Cambodia. Krong Kep is a rural region within the country. It's comprised of 16 villages. My thesis was focused on maternal and child health. So that's so a lot of my early work was very much in women's health, maternal child health. And then stayed on and continued to go back for a few years after that, even going into my PhD work to support with public health programming initiatives. And my PhD program, having the opportunity to work in Cambodia really got me interested in health policy, what this is. I had some interest from the Maternal and Child Health Institute in the country, as well as the Ministry of Health in Cambodia, about the maternal and child health research that I was doing. And that got me really interested in this whole pathway of from research into policy and practice. And what does that look like? What does that look like from a scholarly perspective? And so started to get really introduced to some concepts around knowledge translation and policy impact, and I even program evaluation. So I had intentionally looked for a PhD program that was focused on health policy, that would provide me with some important skill sets and applied learnings. At that point, I didn't know if I was going to go into academia post-PhD or go back to how I began in working in community settings or in the grassroots, but I let the journey take me to where it was meant to go. So after graduating from my PhD program in health policy at McMaster, moved to Alberta, or actually, sorry, I'll take a step back, but there was a lot of good applied research and policy experience that I had gained throughout my PhD. And that's something that I always encourage for my own students, trainees within my research lab, is when the opportunity presents itself, take research assistant positions or other applied work experience that help you to integrate what you're learning as a scholar and into applied practice settings. And that was very much my time in the 4 years or 5 years of my PhD program at McMaster. So I worked for the McMaster Health Forum, writing evidence briefs, issue briefs, organizing stakeholder dialogues, citizen panels around a range of different health policy issues, and also completed a diploma certificate in health policy and services research, which had a practicum placement at the Association of Ontario Health Centres. And that's an association, a body that represents community health centers across the province of Ontario. Then moved to Alberta, post-PhD, did a postdoc at the University of Calgary, where I had brought my health policy skills into some opportunities to work with Alberta Health Services related to community-based primary care. And today I am an associate prof in the School of Public Health, and I teach a course on applied health policy and systems research. And just a few words about health policy and systems research in terms of the boundaries. So health systems research is clearly within the larger domain of health research. But as you can see, perhaps just in the interest of time, figure 2, how it really intersects with a number of other key domains, including implementation science, management science, improvement science. So when we think about designing, implementing, or supporting uptake of new initiatives, new programs, either in community or healthcare settings, the field of implementation science is really helpful in understanding what works or what doesn't work in these different settings. And one thing that we always have to remember working in these applied settings is that the pathways to solving complex issues are often unpredictable and uncertain. So talking just a little bit about some of the applied work that I've done or am currently doing and will continue to do in family violence. And I usually, most of my work is framed around family violence, as a lot of my interest, kind of connecting it back to my background in maternal and child health and my interest in supporting the entire family system. So a lot of our initiatives and programs within the lab do really speak to family violence. Also, as we were engaging in doing this work with Indigenous communities, this was a terminology that they had preferred, as it more aligned with the important role that kinship plays in promoting and protecting health and wellness. So I'm just going to highlight a few examples if I have some time, Tamil. If not, I'm happy to stop here. But if I have 2 minutes, I can run through just a few applied examples.
Go ahead, Stephanie.
Okay, great. So this was one project that we did during COVID, and essentially we were looking with a lot of these services going virtual and domestic sexual violence services being delivered remotely. We looked at what was known about effective virtual trauma-focused domestic violence interventions. So we held policy dialogues. We engaged a number of stakeholders, including service providers across the anti-violence sector in Alberta, to really build the knowledge and understanding. There was a lot of literature on virtual care delivery outside, like in healthcare settings like primary care, acute care, but almost nothing in the context of community-based service delivery or in the anti-violence sector specifically. So certainly a lot to learn about how to do this during the pandemic. So our intention was to provide, real time-sensitive and relevant feedback and guidance for the anti-violence sector in Alberta. To this effect, with the research we generated, we developed a handbook for the anti-violence sector on virtual remote-based delivery of domestic and sexual violence interventions. So here's just a snippet of that handbook, which was circulated widely through a collective network called Impact. So Impact is a collective network that represents 300 plus agencies within the anti-violence sector in Alberta. So it was circulated widely to agencies, organizations in the province. Another example is where there's been significant knowledge gaps is in the uptake of screening practices in acute care settings. So we've been working with the 2 trauma care centers in Edmonton, the Royal Alex Hospital and the University of Alberta Hospital, to support implementation of best practice screening for intimate partner violence in these 2 trauma centers. And a lot of, again, knowledge gaps here. A lot of what is known about screening practices has been in either the emergency department or even in primary care, but not a lot known about what some of the contextual factors or challenges might be in trauma care specifically. And another more recent example was in collaboration with SHIFT, the Project to End Domestic Violence, situated at the University of Calgary, led by Lana Wells and her team, and Impact, which is that provincial collective group that I mentioned. We worked with the government of Alberta on a 3-year project to end domestic violence. So essentially, it led to 33 or 32 policy reports on various different topic areas, all to inform a primary prevention framework for the government of Alberta. These were two that you see here on the screen, two policy research reports that my team had generated. One focused on the role of social welfare policies and programs. The other was looking at the role of social determinants of health. And all of that work was essentially brought into the development of a playbook that SHIFT had produced. So please check out Alberta's primary prevention playbook if you're interested in knowing more about some important plays to prevent and end domestic violence. And lastly, some key conceptual frameworks that I draw on my work, which, as you can see, are very applied and helps us to understand real world contexts, real world policy and practice settings. The one that you see here in the center around systems thinking is one I use a lot when engaging policy actors or even providers in the system. Is really, when we think about transformation, it's about understanding what mental models people hold and how do we shift what we know to either improve, care or services that are provided to individuals and families. That's it from me. Thank you, and look forward to connecting if you have any further questions about the work we do at CARE.